Hi, Assalamualaikum. My name is Nurul Qhairulnnisa Binti Razi, and today I will present to you guys about the radiographic image evaluation of the knee, which is epi and lateral projection. Okay, first thanks to Miss Faika and all of my friends who helping me to finish this assignment. Okay, we proceed we moved on with epi knee. Okay. What is criteria for epiny? Okay, criteria for epiny is first, femoral epicondyles are in profile and the femoral condyles are symmetric. What is the differences between epicondyles and condyles? Okay, the differences is up here. Okay, this is called epicondyle. Okay, and down here is called condyle. Okay. Okay. Next is intercondylar eminence is centered within the intercondylar fossa. Where is intercondylar eminence? Okay. Here is intercondylar eminence. And up here, which is at the distal femur, is intercondylar fossa. Okay. Is centered within the intercondylar fossa. So here, up here. Okay. Tibia superimpose one half of the fibula head, which is the proximal tibia is superimpose one half of the fibula head. Okay, that is tibia and this is fibula. Okay, it is one half, 1/2. Okay. Okay, next is patella lies just proximal to the femoral patella. Okay, this is patella, which is lies as the proximal to the femoral patella surface, and it's slightly lateral to the knee midline. Okay. Okay, and lastly is 1/4 of the distal femur and 1/4 of the proximal tibia fibula is included within the exposure field. Okay. Next is evaluations of the projection. Okay. Why I say it is epi-knee projection? It is because the lateral and medial epicondyles of femur in profile. Okay, here in profile, right? Okay, and the patella lies at the distal femur. Okay. And lastly, femoral tibial joint. Where is femoral tibial joint? This is femoral tibial joint. Okay. Femoral tibial joint is visualized and included 1/4 of distal femur and 1/4 of proximal tibia fibula within the collimation or the exposure field. Okay, next is positioning. Okay. True epi-knee positioning. Okay, how? Okay, so lateral and medial condyles are symmetric. Okay, laterals and medial condyles are symmetric, and the proximal part of the tibia here, okay, and fibula is 1/2 of the fibula, here, of the fibula head was superimposed with tibia. Okay. And lastly is the femoral tibial joint, which is here. Space is open. So that is true epi-knee projection. Okay. Next is, what if there is rotation? How the image? Okay, the image will produce, if the external rotation, the image will produce like this, which is the medial condyle here, as you can see. Okay, sorry, that is epicondyle. Okay, here, this, okay. So you can see the medial condyle, the size is bigger than the lateral condyle. Okay. And second, the evidence for the external rotation is the head, neck and shaft of the fibula are superimposed more than one more than 1/2 of the tibia. Okay. For the internal rotation, for the internal rotation, the lateral condyle, the size of lateral condyle is bigger than the medial condyle. Okay. And the second evidence is the head of fibula, the proximal head of fibula is very little superimposed with the tibia, which is not more than half, or we can say it less than half of the fibula was superimposed with the tibia. Okay, here it's not slightly, it's less than 1/2. Okay, this is fibula and it's less than 1/2. Okay, for the angulations of the beam, okay, here for the image is for angulation to cephalic. Okay, for to cephalic, the fibula head foreshortened and seen more than 1.25 cm distal to tibia plateau. Okay, here this is fibula head seen foreshortened. Okay, and the distal here from tibia plateau and to the proximal fibula head is more than 1.25. If the angulations beam was too caudally, here the evidence is fibula head will seem elongated and demonstrate less than 1.25 cm distal to tibia plateau. Okay. Okay, next is positioning. Okay, positioning, this is evaluation for the positioning and the radiograph of my radiograph that I choose. Okay, first, this is incorrect positioning. I say so because the proximal tibia demonstrate very little superimposed with the proximal fibula head, which is not more than half of the proximal fibula head. Okay, second, the size of lateral condyle is more bigger than the medial condyle, which is internal rotation. Okay, next, the proximal fibula head demonstrate less than 1.25 distal to tibia plateau. Okay, wait. Okay, so to improve this, rotate patient leg externally until medial and lateral epicondyle are equidistant to the IR. Okay, next is alignment. Okay, the alignment between X-ray and cassette cannot be determined since there is no evidence of foreborder of collimations, and the alignment between X-ray and patient cannot be determined because there is no foreborder of collimations, and the alignment between patient and cassette is correct because the distance between the central structure to the edge of the film at the superior and inferior level and both lateral is equal. Okay, so for this radiograph, the centering point for this radiograph cannot be determined because there is no foreborder of collimations, and the standard centering point for this projection is 1.25 cm distal to apex of patella. Okay, so but if the angulation beam will be different if the body thickness of depends on the body thickness of the patient. Okay, for the body thickness of the patient more than 24 cm, so the angulation of the beam must be 5 degree curvature. Okay, if the body thickness of the patient is less than 18 cm, the angulation of the beam must be 5 degree caudally. But if the patient is at the average of the body thickness, so the beam must be perpendicular. Okay. Okay, next is for the collimation. Okay. At the superior border, structure that should be included are patella, distal femur, and intercondylar fossa. Okay, at the both lateral border, structure that should be included are medial and lateral epicondyles and lateral condyles of tibia. Okay, at the inferior border, structure that should be included are tibia plateo, fibula head, and tibia. Okay, next is exposure factor. Okay, exposure factor for this radiograph. Okay. Okay, the KVP used is adequate for penetration and radiographic contrast. This is because the bony cortical outline of the thin structure, which is the lateral and medial epicondyles, are visualized. Okay, and the bony cortical outline of the thick structure, which is patella, are visualized. So okay, for next is the MS. Okay, the MS use is adequate for density and detail. This is because the bony trabecular pattern of the thin structure, which is the lateral and medial epicondyles, are visualized, and the bony trabecular pattern of the thick structure, which is patella, are visualized. So there is no changes needed for this exposure factor and for this radiographic. For this radiograph. Okay, next is marker and aesthetic. Okay, marker, as you can see, there is no evidence of anatomical marker shows in the radiograph. Okay, it should be placed appropriately at the right side, which is not superimposed with the region of the interest and with right annotations of the marker. Okay, aesthetic. Okay, the size of radiograph cannot be determined since it was from internet, and the best film size used is 24 x 30 cm, which is sufficient to demonstrate all the structures of interest, and there is no evidence of artifact on the radiograph. Okay, next, lastly, name and the conclusion for this radiograph. Okay, name. The patient's name and ID, date of examination, place of examination are not visualized on the radiograph. It should be placed appropriately at the appropriate area and not superimposed with the structures of interest. Okay, so the conclusion for this radiograph is not acceptable because there is no patient's name and ID to avoid change with the other patients, and there is no evidence of anatomical marker in this radiograph, which is important to know, which is part that been examined. Okay, we proceed with lateral knee. Okay, for lateral knee, the criteria for lateral knee is patella is situated proximal to the patellar surface of the femur. Okay, this is patella is proximal. Okay, this is patella and this is surface of the patella surface of the femur. Okay, so patella is situated proximal to the patellar surface of the femur. Okay, and you can see here patellofemoral joint is open. Okay, this is open. Okay, and the anterior and posterior margins of the medial and lateral femoral condyles are aligned. Okay, here is the anterior, this is posterior and this is anterior margins of the medial and lateral femoral condyles are aligned, which is superimposed with each other. Okay. Next is proximal tibia superimpose one half of the proximal fibula head. Okay, this is tibia and this is fibula, which is superimposed half of the fibula head. Okay, and 1/4 of distal femur and 1/4 of proximal tibia fibula are included within the exposure field. Okay, next is evaluations of the projections. Okay, this is projections of the lateral knee. Why? Okay, I say so because the lateral and medial epicondyles of femur are superimposed to each other, which is aligned with each other, and the patella seen laterally, and lastly is included 1/4 of proximal tibia fibula and 1/4 of distal femur within the exposure field. Okay, sorry. This is a line of the anterior and posterior. Okay, lateral and medial epicondyles of femur are superimposed with each other. Okay, and the patella seen laterally. Okay. Next is for positioning. Okay, this is for true lateral positioning. Okay, first must be knee must be flexed at 10 to 15 degree, and the patella situated proximal to the patellar surface of femur, just like just now. Okay, and the patellofemoral joint and femoral tibial joint is open. Okay, and the lateral and medial condyles of femur is superimposed, and the proximal head of fibula and proximal tibia is slightly superimposed. Okay, here is slightly or 1/2 of the fibula head or superimposed with the tibia. Okay, and you can see the patella situated proximal to the patellar surface of femur, and the femoral tibial joint is open. Sorry, this is femoral tibial joint is open, and the patellofemoral joint is open. Okay. Okay, next is for the rotation. How to detect rotation? Okay, first we need to determine the medial and lateral condyles. How? Okay, first we need to locate the adductor tubercle and which is located at the posterior on the medial aspect of femur, just superior to medial condyle. Okay, next is distal articulating surface of lateral condyle is flat, while the medial condyle is convex. Okay. Okay. Next is accuracy. If the accuracy of positioning, which is true lateral positioning, so the femoral joint space will open. The distal articulating surface of medial and lateral femoral condyles are superimposed with each other, which is like just now, which is at the anterior and the posterior articulating surface of the condyles was superimposed or aligned with each other. Okay. For the external rotation, which is too close to filum, the medial condyle will situated anterior to the lateral condyle. Okay. Next is anterior and posterior aspect. Anterior and posterior aspect of the femoral condyle are not superimposed with each other. Okay. For the internal rotation, which is too far away from filum, the medial condyle is situated posterior. Medial condyle is situated posterior to the lateral condyle. Okay. So, if the knee flexion is more than 20 degree, the patella will contact with the patellar surface of femur. Okay, let's check it out. Okay, here it is. Okay, first is for the external rotation. Okay, for the external rotation, as I said just now, first we need to detect the adductor tubercle to detect the rotation. Where is adductor tubercle? Okay, this is adductor tubercle, which is posterior to the medial of femur and superior at the medial condyle. So, if we can detect the adductor tubercle, so we will know where the medial condyle. So we can differentiate where the lateral and where the medial condyle. Okay, so this is adductor tubercle. So adductor tubercle, it was superior to the medial condyle. So this is adductor tubercle, which is superior to the medial condyle. Okay. Okay. So medial condyle situated anterior to lateral condyle. So this is lateral condyle. So medial condyle is situated anterior to the lateral condyle. Okay, that is first evidence. And the second evidence is anterior and posterior aspect of condyle did not superimpose. Okay, this is anterior condyle and this is posterior. So they did not superimpose with each other, right? Okay, for internal rotation, the medial condyle situated posterior to lateral condyle. Okay, what is adductor tubercle? This is adductor tubercle, and so this is medial condyle. So this is lateral condyle. Okay, so medial condyle situated posterior at the back to the lateral condyle. Okay, so and lastly, the anterior and posterior aspect of the condyle did not superimpose with each other. Okay, for knee flexions, okay, this picture for knee flex more than 20 degree. So the patella will contact with patella surface of femur. Okay, here, this is the patella surface. It contact with each other. Okay. Okay, next is for the positioning for this radiograph. Okay, positioning for this radiograph is correct. I see. So because the lateral and medial condyles are superimposed with each other, and the patellar femoral joint space are open, and the head of fibula and tibia slightly superimposed with each other, and the flexions of the knee is 10 to 15 degree. I say so because the patella not contact with the patellar surface of femur. Okay. Okay, next is for the alignment. Okay, the alignment between X-ray and cassette cannot be determined because there is no for border of collimations, and the alignment between X-ray and patient cannot be determined because there is no for border of collimations, and the alignment between patient and cassette is incorrect because the distance between the central structure to the edge of the film at the superior and inferior border level is not equal. Okay. So the centering point for this radiograph cannot be determined because there is no border of collimations, and the standard centering point for this projection is 1 inch distal to medial epicondyles, and centering ray is directed at the 5 to 7 degree of curvature. Okay. Next is for the collimations. The collimations at the superior border structure that should be included are shaft of femur, and the epicondyles of femur. At the both lateral border, structure that should be included are patellofemoral joint, patella, and the fibula head. At the inferior border, structure that should be included are tibia plateau, tibia, and fibula. And there is no evidence of radiation protection seen on the radiograph. Okay, next is exposure factor. Okay, the KVP used is adequate for penetrations and radiographic contrast. This is because the bony cortical outline of the thin structure, which is the patella, are visualized, and the bony cortical outline of the thick structure, which is the femoral condyles, are visualized. Okay. The MAS used is adequate for detail and density. This is because the bony trabecular pattern of the thin structure, which is the patella, is visualized, and the bony trabecular pattern of the thick structure, which is the femoral condyle, are visualized. So there is no changes needed for this radiograph. Okay. Next is for the marker and aesthetic. As you can see at the radiograph, there is no evidence of anatomical marker shown, and it should be placed appropriately at the right side, which is not superimposed with the region of the interest and with right annotation of the marker. Okay, for the aesthetic, the size of this radiograph cannot be determined since the radiograph is from the internet. So, the best film size used is 24 x 30 cm, which is sufficient to demonstrate all the structures of interest, and there is no evidence of artifact on the radiograph. Okay, next is for name, and lastly for the conclusion. Okay, name, there is no patient's name and ID. There is no evidence of patient's name and ID. Date of examination, place examination, visualized on the radiograph. Okay, it should be placed at the appropriate area and not superimposed with structures of interest. So the conclusions for this radiograph is not acceptable because there is no patient's name and ID to avoid change with other patients, and there is no evidence of anatomical marker in this radiograph, which is important to know, which is part that be examined. Okay, here is my references that you may refer to. Okay, and lastly, thank you. Bye. Assalamualaikum. Selamat Hari Raya.